about perforations. What's your immediate reaction to a coronary perforation and algorithmic management of the coronary perforation? Couple of different options to treat it, and how do you care for them post-perforation. So this is the Ellis perforations classification. We all know this. Type 1, which is within the wall. Type 2 is in the tissue. Type 3, there's an obvious frank collection of blood. And type 3 also spilling into the anatomic cavity, such as coronary sinus or a ventricular chamber. So obviously, the first step is not to panic, not to lose the wire, kind of take a 2 or 3 second kind of regroup of what's happening with the patient, and then get your help. So this is the perforation algorithm I like to use. It kind of puts things in a place and helps me organize myself. So you have a perforation. Is the patient stable, yes or no? If the patient is not stable, you are already calling for help. Someone's getting IV fluids, or another attending or somebody else who can help you is doing the pericardiocentesis. You're talking to somebody else who's doing your CT surgery. Why is this important? This is not, interventional cardiology is not a one-person show. It's a team sport, and you have to have your team members in place. So let's say if you have a wire cross and the patient is reasonably stable, then great. Yeah, like what Dr. Pratap showed, do a balloon tamponade, kind of get a covered stent, or think of what else you can do. How severe is the wire perforation? Can you just remove all the gear and reverse your heparin? Will that be enough? Will be the way you to think about it. And if despite balloon tamponade with ringer balloon now, as was mentioned before, patient is still bleeding, you can think of coils, thrombins, fat, etc. So these are the different covered stents available for us. So this is a case of a RCA-CTO post-CABG patient, kind of very awkward anatomy, very poor distal visualization. We came retrograde, but and I'm trying to get a knuckle to get into the antegrade across. And you can see my knuckle wire is not behaving well. It's kind of distorting in space. And that distortion tells you that I've created a giant space, and it's easy for the wire to go across. But nevertheless, the patient stayed stable. And I, kind of did the reverse card, everything. I had a guide extension all the way done to help me assist the reverse card. And after that, I removed the guide extension catheter all the way back to do IVIS, and the blood pressure dropped just by like 10 millimeters. It was not a major drop. No one in the team would even notice that drop in blood pressure. But the next picture will tell you why I was concerned. You can see a perforation there, a perforation here, kind of nasty looking RCA, but it's okay. It's only, I have my wire across, it's a retrograde system. I have a guide extension in place which is tamponading this, and I've already modified this vessel, and like it can do whatever I want it to do. So I put 2 covered stents, and this was the final angiographic result. It's not perfect. Patient is stable. There's this staining is just me injecting hard in through the guide extension. And I'm like, get out of here. That's enough for the day. So perforation management, and you always need to have a plan, and how to execute the plan is extremely important. I will refer to Brilakis's CTO or Gianni's algorithm. It's important. Take a printout and laminate it and put it on your cath lab if you need to. It's good to have this plan in mind. Then you have to know how to use your fat, coils, microspheres, etc., etc. And fat easily available, whereas the coils, you need to know the compatibility between the microcatheter and the coil. And thrombin, at least in America, it's a problem. We have to call pharmacy. Pharmacy has to get it. It takes about 20 to 30 minutes, which we don't have. So we usually have Azure coils, Terumo coils, or which can be Axiom coils, can go with a fine cross. That also is easily available. Fat is take the bit of fat from the femoral artery incision, macerate it with contrast, so that, and then the most important thing is it needs to float up here, so you kind of tilt it to make it go up. This is a LAD CTO. I did an investment procedure with a Mongo wire knuckle, and 6 hours later, patient was hemodynamically unstable. So with the effusion like this, brought her back to the cath lab, and you can see that my knuckle had caused a wire perforation. Balloon tamponade, got the fat and injected the fat, And yes, there's no CT, no flow in the beginning, no flow at the end, but she's alive and lived to go fight another day. Then coming on to deploying coils, these are the different ways you can deploy a coil. Basically, once the coil exits the wire right here, it kind of accumulates and coils up. You have just a little insert device. You insert and you press the button, you hear a ping noise and the coil is deployed. And sometimes you can have to break the back end and the coil is deployed. So different ways. Know your tools, and that's why this conference is fantastic. It's not enough if you just know to do a rotational atherectomy. You need to know what to do when a burr is stuck. You need to know, you need to be able to manage the mischief you have created in the cath lab. So sometimes this is a crazy case, RCA CTO, look at all these sternal buttons. I could not get any device across, so I had a 1.5 balloon which did not cross, did laser, and the laser caused a perforation. It looks nasty, but the patient was rock solid stable. His echo was completely like this, and we had inflated the balloon while we were assessing him. I turn around and I look at my deflator, my balloon had ruptured because it was such nasty calcium. So basically he was stable. We came back another day and fixed his RCA. This is another patient. It's a RCA CTO, but I created a bunch of septal hematomas. And if you look at the echo, there's no effusion, but you can see the hematoma collecting in the septum. And if you leave it like that, it can enlarge and cause almost like a man-made hypertrophic obstructive cardiomyopathy and dry tamponade physiology. So I decided to put a couple of coils there to save the day and figure out thing. Now, I'm going to take 1 minute to talk about contrast enhanced echocardiography for perforations. It's a great tool. We all have it. Optison is already available in it. It is basically when you can't figure out, is there a perforation or is this actually collecting in the pericardial space or what is happening? You can take the definity contrast which the echocardiographers have and mix that with your contrast and inject it while they have the probe, and you can see the contrast bubbles, definitely bubbles going in the pericardial space. That's a neat bedside tool which you can use. And the bottom line is post-procedure, stay involved. You can't just do all this and walk away. Update the family, serial echocardiogram. Consider protamine once the gear is out. Prior cabbage does not decrease the risk of tamponade. It actually makes your tamponade management even more annoyingly difficult. So, but you have to have a team. You need an interventional radiologist who will do CT guided, drain through some weird space or something like that. If post cabbage, sternotomy is not an option, but they can do a left lateral thoracotomy to relieve the tamponade. So you better have a good relationship with your cardiac surgeons as well. Debrief the team. This can be very traumatic for the team. So talk about what happened, where did you go wrong, what could you have done differently. It's not that you have done something wrong. You, in good faith, believed that what you did is going to result in a great outcome, but because of multiple patient features, etc., it ended in a bad outcome. So you didn't make a mistake, but you were put in a milieu where the odds were not in your favor. So the team needs to understand that, to trust you again and come back and do the procedure. So multiple algorithm. While they say there's an app for it, I'll say there's an algorithm for everything. With that, I will finish my talk.